Good evening, everyone, and thank you for joining us for the Managing Cancer in Primary Care, an overview of breast cancer, early pancreas cancer, and endocrine therapy toxicity management with the Kinghorn Cancer Centre. My name's Kylie Somerville, and I'm the Manager of Population Health and Chronic Disease at Central and Eastern Sydney PHN. Also with us tonight from the PHN is Lauren Thomas, the CPD Program Officer. I'd like to start by acknowledging the traditional custodians and sovereign people of the lands across which we work. I recognise their continuing connection to land, water and community, and pay respect to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander people joining us tonight. Just some housekeeping. At the end of the webinar, the evaluation survey will be available from the chat box and will also be sent out to your email. We really appreciate your feedback, so please complete this to allow us to issue your certificate of attendance. For GPs joining us this evening, this activity has been approved for 1.5 hours of educational activity. These will be uploaded to RACGP after the event, but please give up to a week for this to be added to your dashboard. Throughout the presentation, please submit your questions in the Q&A box and they'll be answered at the end of each presentation. I'd now like to draw your attention to the upcoming events on the screen, and registrations for these events are available on the PHN website. I'd like to introduce Mary Hayes, Medical Oncology Primary Care Clinical Nurse Consultant for the GP CanShare program at the Kinghorn Cancer Centre, to give a short introduction about the GP CanShare program. Thank you, Mary.
Kylie, I'll just share my screen very quick. So hi everyone that's online. So as Kylie mentioned, I'm one of the GP CanShare nurses based at the Kinghorn Cancer Centre of St Vincent's. We're in our third year of the project now at the Kinghorn, and we've met many GPs and practice nurses along the way. Some of hopefully are joining online tonight. The overarching aim of this project, as we know, is to enhance cancer management in primary care. And really what we focused on here at St Vincent's is improving the communication that goes out to GPs and to nurses, and providing that direct contact for nurses and GPs to contact us directly through the liaison service based at the Kinghorn. So as you probably know by this stage, we're based across the region, so not only at the St Vincent's, but across Sydney local and southeastern Sydney as well. And so our contact details are just on the screen. If you've got any patients that are either linked in with the service or that you want linked in, please reach out, give us an email or a call. Or if there's any more questions about GP CanShare, we'd be happy to have a chat offline. That's all from me. Thanks, Kylie.
Thanks, Mary. So our first speaker for this evening is Dr. Joshua Hurwitz, who is a medical oncologist currently completing a fellowship at the Garvan Institute of Medical Research in Sydney, specialising in breast and genitourinary cancer. Dr. Hurwitz is presenting tonight on management and treatment of invasive breast cancer and toxicity management of patients receiving endocrine therapy. Thank you, Dr. Hurwitz.
No worries. Thanks so much for having me. Just give me a second as I share my slides. So many slides. There we go. Perfect. All right, that should be there. Give me a second to share. Perfect. Can you guys see that?
We can see it. Thank you.
Wonderful. So I realized that when I decided to talk about early breast cancer, it's a huge topic because breast cancer is huge in itself. And my slides are a little messy. So I'm going to try and focus on the important things, the things that I think that if I was in the community or when I was an early registrar and had no idea what I was doing, I would have loved to know these little tidbits, because I find our patients want to know everything right away. And sometimes that can be really challenging and quite daunting. Okay. All right. So this is just a background. It's quite an extensive background, but going to go through the subtypes, ductal carcinoma in situ, lobular carcinoma, early breast cancer management, and just some long-term considerations. So the breast cancer itself, the most frequently diagnosed malignancy globally. In Australia, it's only secondary to prostate now, but it has lost that crown recently. And it's highest in developed countries such as Australia, New Zealand, Eastern Europe, and North America. Rates are declining of mortality purely because we have better detection and better treatments, and 6% lower risk of dying because we do these things. And for early stage breast cancer, overall survival is 99%, which is phenomenal and somewhat different to Meg's story of pancreatic cancer, but I won't spoil the second part of our show. When looking at the background, you can kind of see here the age of diagnosis, how it changes, higher in those sort of 50 and above, and then drops off again after the age of 70. And stage 1 survival, 99%, and even stage 3 survival is 80%. And that's improving every year as our treatments evolve. Risk factors, hormone replacement therapy is probably my big bugbear. Please make your patient stop. I know it's great for these sorts of symptoms that people get from a menopause perspective, but the risk is there. And it does actually reduce once you stop the HRT. So that's something that you can sort of sell with respect to that. Family history is important, obesity, menopausal status, Caucasian, and the older you are, and an extensive history of smoking and alcohol. 50% of breast cancers present with a breast mass that's not detected on mammogram, meaning you might need an ultrasound or an MRI, and a further 30% will present in between mammograms, meaning that whilst mammograms are wonderful, they don't pick up everything. The symptoms you might do if you examine someone: hard, immovable, single dominant lesion, irregular borders, and if someone has very dense breasts, that will be very difficult, and so you'll look at investigating that further with other imaging. When it progresses, you might get fungating wounds, skin breakdown, but this is early cancer, so I'm not going to talk about the later stages. So what imaging is available to you? So the classic mammogram, you'll do a mammogram and ultrasound. That's the standard of care. And more than 90% of breast cancers are identified on a mammogram. And your spiculated mass, microcalcifications, these are all the yucky things we look at in those reports. And then you've got tomosynthesis, slightly better than classical mammograms at localizing, but it's only really utilized in the screening process rather than treatment process. And then you've got the MRI. So the issue with the MRIs is that I believe a lot of these are out of pocket initially. And then once you have a diagnosis, then it is not out of pocket. So there are those financial considerations. They're good if you've got conventional imaging that doesn't give you the results, if you've got chest wall involvement, if you don't see everything on a mammogram, really high sensitivity, and will pick up an extra 5% of patients who have previously not had their cancer detected in the contralateral breast. When it comes to perioperative MRIs, the statistics don't show improved overall survival, but again, statistics are difficult when people live so long and we have such great standard methodologies as well. A little bit of things what you do next. You do a breast biopsy or a biopsy of an axillary lesion, whichever one is easier. And you want to get that tissue. You want to make sure you can figure out what sort of cancer it is, because that's going to determine how you're going to treat it. Some of my patients ask about other staging, so things like CTs, PET scans, bone scans. The statistics are a little bit difficult to ascertain in the sense that, there's not a lot of strong evidence to support doing a bone scan, which looks at all your bones, doing a CT chest, tummy, and pelvis in regards to what you're going to do when you're looking in an early breast cancer. It does come a little bit down to specialist considerations. Some specialists will do it as a baseline, just be like, okay, we've got your diagnosis. We know at this point in time, you have no cancer, which is wonderful. And that way we can then follow you up. And we know without a doubt that there wasn't anything lurking behind. Because a lot of the time, early breast cancers, you won't get CTs and you won't get PET scans and you won't get bone scans. And these are important things to discuss. And when you look at the literature, I put some of the statistics in, a bone scan will pick up 6% of patients you might find in metastases, and a liver ultrasound in stage 3 cancer, you're 6%, but at stage 1 and stage 2 never picks it up. But again, to the individual in that statistic, it doesn't actually matter. And so that's why it's actually a complicated situation, and it should be a case-by-case basis. So I'm going to talk a little bit about some precancerous lesions. So precancerous includes ductal carcinoma in situ and lobular carcinoma in situ. The difference is really ductal carcinoma in situ hasn't gone through the actual duct. So it's still located within the duct and it hasn't broken through this. So that's why it's not called invasive. Common in the ages of 50 to 65. You see it as high as 88 per 100,000 women, and it represents about 25% of all breast cancers diagnosed in the United States. The good news is that DCIS has incredibly great long-term breast cancer specific survival of about 98% after 10 years of follow-up. So that's great. And, if you've got someone who's 60 or even let's say 70, 10-year survival, 98% from a breast cancer perspective is exactly what you're trying to do. The risk of developing invasive carcinoma is a bit unknown and a little bit complicated. And what that means is that it does increase your risk. And most patients will not require a sentinel lymph node biopsy, and it will only be done in those with high-risk features. When you look at local treatment, you might have a wide local excision, which is just cutting out that spot. And some people will opt for a mastectomy, being like, I don't need radiotherapy. I've done all I can do. I'm happy with my decision. And that's really a conversation for the surgeon. There's pros and cons to all of these things. So radiotherapy is generally the standard for patients treated with breast conserving therapy. And there are, of course, exceptions to the rule. Advanced age, lots of comorbidities, small foci of very low-grade disease. It's a risk versus benefit, right? So if the risk of the complications of treatment outweighs those benefits, then you're not going to do it. So that's a sort of a conversation as well. But what they found is that, the hazard ratio is 0.49, meaning it's about 50% better than not treating. And you need to treat 9 women to prevent 1 ipsilateral recurrence. So not a huge number of patients that need to be treated. The other complicating factor is, how do you define low risk? There aren't any specific criteria, which makes it hard. The other management is you're going to cut it out. 75% of ductal carcinomas are hormone receptor positive, and 25% are other subtypes, being that human epidermal receptor growth factor positive or triple negative disease. For those in the hormone receptor positive space, you'll likely give endocrine therapy, and you can give either tamoxifen or an aromatase inhibitor. The data doesn't show overall survival, which is all a bit sad, but it does show reduced recurrence and improved breast cancer-free survival. And you wouldn't use this if they were hormone receptor negative as well. This is from quite an old trial, and excuse me, I cut off the top, but the solid line is tamoxifen. The dotted line is the placebo in this group. And you can see the cumulative incidence decreases for recurrence by giving tamoxifen in the ductal carcinoma in situ group. Next, we have lobular. So this represents a smaller portion of, I guess, the non-invasive cancer components, and generally the risk of getting an invasive cancer from a lobular is about 9 to 10 times that of the general population. It affects those that are slightly younger and can be multicentric and bilateral. These cancers, or these pre-malignant cancers, have a higher risk of developing invasive breast cancer than the general population. Although most will still not develop invasive cancer, but we're still going to cut it out because that risk is there, and that risk is not insignificant. So the cumulative incidence of subsequent breast malignancies was 11.3% and 20% at the 10 and 20-year mark. So not infinitesimally small, and something that definitely needs to be addressed when it comes to looking at, risk reduction. Because prevention is always better than a cure. So the management is you excise it, you cut it out, you either get a mastectomy or wide local excision, and then you have surveillance, being yearly mammograms and twice yearly breast examinations as a minimum. As I said previously, stop the oral contraceptive pill. Well, I didn't say that, but I'm saying that now. So stop the oral contraceptive pill, avoid hormone replacement therapy, lifestyle and dietary changes. So if they're smoking, ask them to stop smoking. If they're overweight, losing weight is going to be beneficial. Exercise is a wonderful tool, and dietary changes like a healthy Mediterranean diet. And realistically, surveillance should last the patient's lifetime, or when the patient no longer wants to undertake treatment if a cancer is found. But a lot of our patients, especially where we treat, will want treatment sort of ongoing. A lot of our patients will give sort of endocrine therapy or low-dose endocrine therapy as chemo prevention. Lobular carcinoma in situ and lobular carcinomas are very sensitive to endocrine therapy because we stop that hormones being released, and that's what drives these cancers. And that's what we do to try and sort of risk mitigate it. This is a bit of a rapid fire session, and it's a terrible slide, but it goes through the breakdown of the different types of early breast cancer. So you've got invasive ductal carcinoma. Infiltrating and invasive are the same thing. They account for about 80% of all breast cancers. Then you've got the lobular carcinomas, which are about 8%, and then you've got a mix of the two. We then sort of break it down again into sort of luminal subtypes. So luminal A, which is about 40% of the ductal carcinomas, high hormones, low HER2, low Ki67, and a low grade. So Ki67 is the marker we use, which is like that reproductive marker. So if Ki67 is really high, you get a little worried because that's the number of cells that are replicating at any given time. In the triple negative space, you see that anywhere from 30% higher. I've seen ones up to 100. And in the hormone receptor positive, I've seen ones as low as 1%, which means they're pretty slow. And the grade also reflects all of these things. Then you've got luminal B, which is you might have high HER2, but you've got a higher Ki67 and a higher grade. They're a bit more aggressive, and they will likely determine more aggressive treatment because of that. The HER2 component is a little bit interesting because it's about 15% of cancers as a whole, and prior to 2009 had pretty bad rep. So it was lots of recurrences, lots of bad metastatic cancer. And then trastuzumab, one of the anti-HER2 monoclonal antibodies, came along, and the world changed for these patients. Very highly curable in the metastatic setting. People live for years and years and years on these treatments, which is absolutely incredible. And then you've got the triple negative space, which is again a pretty difficult subset of patients to treat, but newer treatments are emerging. With the ER negative subtype, so that's about 20% of all breast cancers, and most fall under the category of triple negative. You have the low HER2 expression, the ER negative, and the PR negative, and there's variations of those things. We divide patients, we classify them as either early, locally advanced, or metastatic, and that all comes into the size of the tumor and whether it's spread to things like lymph nodes or distant organs in the body. If it's spread to a distant organ, we're going to define that as metastatic, and most of the time that is an incurable disease, and all of our treatment is to try and control things. And if it's locally advanced, we're thinking large lesion, has it gone into the axilla or the lymph nodes, or has it spread somewhere sort of loco-regionally? And that will require quite aggressive treatment and has a higher risk of spreading. Whereas earlier cancers that are caught very early are very, very curable. As you saw the graph of the overall survival of these early breast cancers, they do really, really well. I saw this from Dr. Julia Chen, who gave this talk last year, but I quite liked it because it shows a shifting paradigm, and the actual treatment itself, I don't think is the highlight of this story, and isn't going to give a lot of strong information for caretakers in the community, because you want to know what's happening, but also how do I manage those toxicities. It all used to be you were diagnosed with a cancer, you had a surgery, and you gave extra treatment to reduce that risk. It's actually changing a lot. So now we're giving a lot of neoadjuvant treatment. So that's treatment before surgery. So either that's HER2 therapy, chemotherapy, immunotherapy, kind of the big classes, and the targeted therapy. We want to shrink that cancer, cut it out, and then we might give some extra therapy. And there's quite a correlation between complete pathological response, which is killing all those cancer cells, cutting it out, and then that's going to infer increased overall survival longer term. And our arms of treatments are chemo, endocrine therapy, immunotherapy, and targeted therapy or monoclonal antibodies. They're kind of the main classes. So the treatment of these different subtypes, the treatment of invasive breast cancer will depend on subtypes. Not every different type of cancer has a different treatment regimen, and because of that, it becomes quite confusing for our patients, for staff, and for anyone who's trying to manage these things. The early stages, a lumpectomy or a mastectomy plus or minus radiotherapy is kind of the baseline, with maybe some treatment beforehand. And the HER2 space and the triple negative space will have neoadjuvant therapy first. So breast conserving therapy is, people can keep their breasts, they get a scar, but overall they do quite well and they heal quite fast. Things that we would probably not recommend breast conserving therapy, and again, that's kind of the surgical domain. People that have multicentric disease, so lots of spots in the breast, really large tumors. If it's really calcified, it's going to be a very difficult surgery. If they've had prior radiotherapy, which means they might preclude them from the radiotherapy. If they're pregnant, if they've got positive margins. Positive margins are bad because it means you've still got some cancer there. And of course, the other subtypes that I haven't mentioned, inflammatory breast disease, so that's quite aggressive. If they've had radiation, which I've also mentioned, those that have some quite bad mutations, so things like BRCA mutations, so BRCA1 and BRCA2, that means they're at an increased risk. And so we'd probably recommend a mastectomy, but again, that's the surgeon's domain. And then after that, there's lots of extra questions like reconstruction. Do they have a modified mastectomy, a simple mastectomy? And that's all gone through. We go through that during the process of the patients, and they make informed decisions about the pros and cons of each of these. The role of radiotherapy, why do we do it? Is that a bit archaic, having radiotherapy? No, it's going to very much reduce the risk of recurrence locally, and it'll kill. If there's any extra cells that are sitting sort of around that cancer, it should kill them. It's very important, involved margins, lymph nodes, those things. Should you care if someone has a positive lymph node or a suspiciously positive lymph node? Yes, because positive lymph nodes should be cut out, and it will definitely influence any systemic therapy that we do. And when it looks at the other things that we look at for treatment, there's patient factors, right? So what's their preference? Do they want treatment? Do they not want treatment? They're allowed to have informed decisions. Comorbidities, if they've got renal failure, if they're on dialysis, if they've had, a transplant, these are all quite complex decisions that you have to take into account when you're looking at treatment, life expectancy, and complications from our therapy. And you've got the genetic factors, which I mentioned. So BRCA mutation increases your risk of breast cancer and ovarian cancer. And of course, disease factors, right? So if it's a very low risk cancer, you're probably going to be able to avoid chemotherapy in an early breast cancer space. If it's higher risk, then you might have to have a different conversation. We have some testing like the Oncotype DX or the MammaPrint, and there's a couple of other risk stratification scores, which you can use in the postmenopausal space. And they look at, so if I give chemotherapy, what's the likely it's going to benefit? And it's a conversation because that testing itself doesn't cover everyone. And of course, things like triple negative breast cancer are very much going to advocate very strongly for treatment very early on because it is aggressive. For the triple negative space, again, differs depending on institution, but if it's above 0.5 centimeter, most patients will get neoadjuvant as treatment as standard of care, which is usually a combination of chemotherapy plus or minus immunotherapy. That's based on 2 major trials called the Brightness trial and the Keynote trial. I just like the name, so I thought I'd stick it in. And evidence has shown that, as I said before, complete pathological response reduces the risk of recurrence. Interesting, so 40% of patients with stage 1 to 3 will experience a recurrence on treatment. And immunotherapy improves event-free survival by 27%. So these are pretty big numbers. And of course, HER2 positive, I've already kind of gone through this, but neoadjuvant therapy we mostly use, and then we have surgery, and then we'll probably give adjuvant therapy too. Hormone receptor positive breast cancer, this is kind of just showing a little bit of the benefits of the different regimens, but anthracyclines reduces mortality, increases overall survival, and reduces recurrence as well. And we have different combinations that we use depending on the risk and depending on the preference of the patient and toxicity profiles. So what do you look out for? This is probably the most important section when it looks at, I've only got 5 minutes, which is, I'm sorry, I'm a bit of a talker. So chemotherapy, hair loss, myelosuppression, low immune numbers. If they ever have a fever or temperature above 38, they go to ED. When it comes to nausea, it's very easily manageable and we have heaps of medications, right? But patients just need to have it. And the same goes with diarrhea. Fatigue is one of those quite difficult ones. And if anyone's looking for a trial, ASH Malala is currently recruiting for patients with cancer of any type. And that's out, I think, at Concord Way for sort of a survivorship cohort. And then what else to look out for with chemo? So tingling of the hands or feet, poor taste, do they have a rash? Do they have thrush in the mouth, which can make their taste buds pretty bad? And the HER2 therapy, so I've just quickly gone through chemo because we see them every couple of weeks, and HER2 will see them maybe every 9 weeks, maybe every 3 weeks as patient preferences. But we check their heart because it make their heartbeat less strong. But the good thing is that's all reversible and we get the echoes. Rarely lung fibrosis and usually really well tolerated. And I'm going to skip that in the context of time, but I do want to talk about endocrine toxicities. And I think this is where it can be really difficult because patients can either do really well or can struggle significantly. So tamoxifen, which is used predominantly in premenopausal women, hot flashes are quite common. And venlafaxine or oxybutynin can work quite well. Also exercise. Exercise is key. Joint aches, regular paracetamol, pulmonary embolism and uterine cancer. I think those stats are maybe a little bit old, but they're very uncommon. And the benefit of reducing the risk of cancer occurrence far exceeds that of the risks of either a PE or uterine cancer. But of course, we'll ask about these because that will influence which drug we use. Moving on, you've got the aromatase inhibitors. That's another class for the postmenopausal women. Again, they can cause similar things, but we check their cholesterol. It can cause vaginal dryness and increases the risk of things like osteoporosis. We generally will do a bone mineral density scan, and a lot of the time people are starting to give denosumab or Prolia sort of adjuvantly to try and reduce the risk of that happening. So we've got a pretty big breast cancer team. That's me, Josh. We've got at least 3 specialists, a couple of fellows. We've got the McGrath nurses who are just a wealth of knowledge for patient sort of care. We have a big sort of radiation oncology department. We've got a number of surgeons, and we've got genetics and all the allied health stuff. So you're not alone that if someone's not eating properly or feeling down, we have lots of services, especially in the allied health space, that are all free. And we do encourage people to let us know and we can refer them to. And I think that's just really important because this is a bit of a journey. A lot of these patients' treatments, they're all confronted with their mortality. A lot of people are young. They might have families, they might be sort of the primary carer at home, and having 6 months plus of treatment and having to see an oncologist in your 40s is pretty daunting and pretty rough. We also have a large clinical trials portfolio. So we do lots of phase 1 trials. So people in the later stage of breast cancer, they have lots of different options with us that if they fail standard of care, we can then move on to other such treatments, which is really promising and actually helps and provides hope. And we actually see these things come to fruition because breast cancer is at the fore of new drugs and, improving overall survival. I think that's my time almost up. As a final thing, if anyone is actually interested in learning more about different topics, I do run an educational podcast. It's aimed at sort of medical students all the way up to specialists, but it covers lots of topics. It goes through a lot of the data and we try and break it down. It's with a colleague of mine from Melbourne who works at Austin Health. And it's quite good if you're being like, why did they give them this drug? Or what does this mean? And so I hope you guys learned something. I hope it somewhat was beneficial. We want to be called if you guys have questions. I think that's also the baseline. I tell my patients, please let us know if you're not feeling well. And a lot of the time they don't, but I do want to hear about it because we can generally manage most of the symptoms and most of the side effects. And that kind of improves compliance or improves adherence and makes the patient journey a lot more tolerable.
Thank you so much, Josh. That was a fantastic presentation. I'll just wait a moment to see if anyone has any questions that you can enter in the Q&A box. We have a couple of minutes if anyone would like to ask Dr. Hurwitz a question before we move on to our next speaker. Can you see the questions, Josh, or do you want me to read them out to you?
Any comment on satiated and antihypertensive risks? Give me a second. So I think the question is asking, is there any association of breast cancer with antihypertensives, antidepressants, and reducing the risk with statins? So I don't know. I think that's the first thing to say. Look, I haven't read anywhere in the literature that we commonly have a association of antihypertensives and antidepressants causing breast cancer. Statins in itself, I know in prostate cancer, we generally use it. It can actually treat some prostate cancers and bring down PSAs, especially in the metastatic space. But I think that's probably as much as I know. It's not something that we don't stop antihypertensives. There's not a huge association that I've seen from a personal clinical experience that people on antihypertensives present with cancer.
There's just another question there, Dr. Hurwitz saying the role of Evista.
Just looking up the other name. So there's going to be another name. That's probably actually not my specialty. So this is used to present osteoporosis in women after menopause. So what we would normally do if osteoporosis is kind of the concern, or osteopenia, we generally actually refer them to an endocrinologist to manage it. I think it's also really the question that, what we're looking at here is not so much a single point in time. We're looking at a long standing point. So, a lot of our patients might be on endocrine therapy for up to 10 years. And if you're at that 10-year mark, and let's say you're 65 and you've got terrible bones, that can be really distressing for patients. So we usually act on it quite early, and they'll have regular bone mineral density scans. We'll engage a local, our friendly neighborhood endocrinologist who will come down and sort of help us with that if we need it. There's a whole host of treatments. Look, I don't use Evista. We usually use a cluster or denosumab or Prolia. Good thing with denosumab, it's once a year generally. Prolia is every 6 months. And, the other ones can be sort of a tablet form every sort of week or day or month as well. So the best way to investigate dense breasts, it would be an MRI. So mammograms and ultrasounds can struggle, and a breast MRI is better. Because yes, when you're examining a dense breast, it's really difficult to feel any lumps or bumps or masses. And even with mammograms and ultrasounds, sometimes they won't pick it up. So if you're worried, an MRI breast can help sort of clarify it. And what I'd also do, I usually would engage a surgeon and sort of discuss it at an MDT, because these things can be difficult, especially when you look at a mammogram and you might say, look, this is maybe a speculated mass, maybe there's some calcifications, and all of a sudden it kind of changes. And, I've seen this before where that's nothing on an MRI. And then you look at the other breast, which has also been examined, and there's a lesion. So that's the best way to investigate a dense breast.
If there's no more questions, then we might wrap it up there with you, Dr. Hurwitz, and thank you again for your presentation.
Yeah, no worries.
And we'll move on now to our final speaker for tonight, who is Dr. Meg Barnet, who joined the Kinghorn Cancer Centre in 2017. She's a medical oncologist and senior scientist specialising in gastrointestinal and lung cancer, with special interests in immuno-oncology and genomic sequencing. She's currently based in the immunology department at the Garvan Institute. She's the clinical lead of the National Exceptional Responders Program, a clinical lecturer with UNSW Sydney, and a member of the St Vincent's Human Research Ethics Committee. Dr. Barnet is presenting tonight on common presentations, management and post-op care of patients with pancreas cancer. Thank you, Dr. Barnet.
Thanks, Kylie. I think I have to ask Dr. Hurwitz to stop sharing. I often have to ask that, but there we go.
Too much sharing.
Too much sharing. Now, hang on. Are you guys seeing presenter view or not?
Yeah,
presenter view there?
The presenter view. Yeah, that looks right.
Oh, you're seeing the proper
sorry,
slide?
yeah, it looks correct. Yeah, that's right. It's just the slide, no notes.
Excellent.
Yeah.
Thank you. Okay, so Thanks for going first, Josh, and giving a good impression of our centre. We truly did not plan to present the two ends of the spectrum in cancer, but that's ultimately what we're doing, going from a survival rate of 99% to pancreas cancer. So I'm going to talk about early pancreas cancer, particularly the presentations and perioperative care. Start with a brief introduction, then how we define early pancreas cancer, talk about the role of perioperative chemotherapy, and then broadly methods of surgical resection and the relevant features of postoperative care, and summarize. Pancreas cancer is increasing in incidence. Beyond that, beyond what we would expect with improved diagnosis alone. So the cases have more than doubled in the past 20 years, with nearly 4,000 cases in 2020 compared with less than 2,000 in 2002. The median age has stayed about the same of 70 to 72 years, slight male preponderance in 1.3 to 1 cases. The vast majority of cases are of the exocrine pancreas rather than neuroendocrine tumours and unusual cancers that make up less than 5%. And they're mostly in the duct, so pancreas ductal adenocarcinoma, which will be abbreviated through this talk as PDAC, PDAC. The incidence is highest in Western countries and in high-income Asia-Pacific countries, so it's not a disease of the developing world. And stage for stage, it's got the lowest survival of any major cancer. Importantly, in our practice, and something that you can check has happened for your patients, is that for unselected patients, so regardless of family history, around 10% of patients will harbour a germline mutation in a homologous recombination repair gene, such as BRCA2. So routinely now we should refer for genetics screening if patients are interested in pursuing that. Some patients are not, but they should be aware. Defining early pancreas cancer is the subject of a lot of multidisciplinary team meetings. So for staging, when someone presents, and the slides are possibly a little out of order here, we'll talk about how they might present in the next slide. The initial investigation is usually a CT. We should include the chest on that CT. And if we can do a pancreas protocol, that's particularly helpful. That's a protocol that has portal and venous phase and also a pancreatic phase, which is slightly more delayed, which can help differentiate neuroendocrine tumours, venous thrombosis, hepatic lesions, cysts, pancreatitis, all of the things that determine how a patient might progress. FDG PET scans are not funded for this indication, but sometimes we get very confused with anatomy between bowel and pancreas if we're particularly wanting a PET in a patient that can't self-fund, which I think is the majority of patients should not need to self-fund that. Usually used when we're trying to find a reason not for them not to have surgery. It's very important that we select patients for surgery who have a decent chance of doing well in surgery. So after all of that, only about 15% of new diagnoses are upfront resectable. A large portion of them are what we would call borderline resectable, and the remainder are locally advanced or metastatic. But the interesting thing with these definitions is that there is no definition. There's no internationally accepted definition of what is resectable, and it's very surgeon dependent, radiology dependent, and centre dependent in terms of what is deemed resectable or not resectable, loosely based around the association of the tumour with the major vessels, the celiac artery, superior mesenteric artery, and common hepatic artery. and also the superior mesenteric vein and portal vein. Obtaining tissue and sufficient tissue in pancreas cancer is more challenging than in most tumour types because of the retroperitoneal location. Endoscopic ultrasound has really evolved over the past 5 years or so in terms of the ability to visualize not only the mass but nodes around it to give staging information, as well as to traverse a needle through the stomach into the pancreas. If a patient needs biliary decompression, then endoscopic retrograde cholangiopancreatogram is a good option as well, ERCP. It's very difficult to get a decent amount of tissue from ERCP. Used to be fine, but now that we have a dozen, we've got lots more markers that we're interested in looking at, the pathologists always need more tissue. Staging laparoscopy is not routine, but in cancers that are more than 3 centimetres or a high tumour marker CA 19.9, particularly if they're in the tail of the pancreas, we know that PET and CT don't pick up peritoneal lesions that are less than about 1 centimetre. So if we're wanting to make sure that we operate on the correct patients, then we would do a laparoscopy on those patients before proceeding. And then biliary drainage as well, if the bilirubin at presentation is more than about 20, or if we think there's going to be a significant delay with a head of pancreas lesion, we should stent. TNM staging is not as great in pancreas cancer as in other tumours, although it does loosely correspond to prognosis, but very small lesions don't necessarily do well. So T1A lesions are less than 0.5 centimetres, and about 1/3 of those are already metastatic at presentation. Long ago, someone gave me the analogy of a chocolate chip cookie, and I've searched for a better analogy because this one seems flippant, but I haven't found one. Pancreas cancer has a really dense, voluminous stroma around it. And that's part of the reason it's difficult to treat, and part of the reason it spreads early is that it's very vascular, and but the fibrous stroma is hard to infiltrate with treatments. So that also means that radiologic response, if we give neoadjuvant treatment, so treatment before surgery, is very rare. You don't often see a big shrinkage. And also major pathological response. So when we've given treatment and then they go to surgery, we don't see the amazing responses that they see in breast cancer. So a tumour regression score of 2, which means there's still cancer cells there, is actually very good in pancreas cancer, and it does portend a better prognosis. Other centres like MD Anderson in the States use something called biological staging in pancreas cancer alone, because the ECOG performance status of patients is really, really important for how they do. And that likely relates to the importance of chemotherapy in all of this, and the toxicity of chemotherapy and whether they can withstand that. And biological staging also incorporates the CA 19.9 tumour marker, which is a cell surface protein on pancreas cells and on other internal organ cells, but more so expressed in pancreas and elevated in about 80% of pancreas cancer cases with high prognostic significance. So high CA 19.9 is a poor prognostic indicator. More than 500 is defined as metastatic disease in some settings. By some criteria, and a lot of trials in the adjuvant setting, so treatment after curative intent surgery, will only admit patients with a CA 19.9 of less than 180. Less than 100 is much more reassuring that the disease is not metastatic. It's not a good screening tool, so it's not specific. Things like cholestasis, cirrhosis, any other peritoneal irritation can elevate it. So the positive predictive value of a CA 19.9 that's elevated outside of other risk factors is still only about 1%. And then another way of staging that we're looking into is ctDNA, which is particularly of interest because Australia, through Peter Mack and Jeannie T and the team there, are really leading the way with ctDNA work. Perioperative treatment for pancreas cancer is really important because the outcomes for surgery alone are very dire. So the majority of cases are systemic diseases from the get-go. And the 5-year overall survival rate without chemotherapy perioperatively is around 10%. In fact, in the original Conco trial, the 5-year survival was 5.5% in the observation group. But to be fair to the current situation, we're now much better at surgical techniques. And in the completely resected group, that number was more like 10%. But it really highlights that whatever way we can get effective chemotherapy into the patients around surgery is important. So the first slide here just talks about neoadjuvant chemotherapy, so chemotherapy given before surgery. This has been a talking point recently because some centres give chemotherapy to all patients before surgery, whether they're resectable or not, as in upfront resectable. And that was questioned a little bit at a recent major conference. But for the purposes of today, we'll talk about the common use of it, which is conversion for borderline resectable disease. And in that setting, by giving very intensive chemotherapy for about 3 months, we can get about 1/3 of patients who are not upfront resectable to a state where they are resectable and successfully get through surgery, successfully defined as a complete or R0 resection. The benefits of giving chemo first, theoretically, you treat the micrometastases that you can't see on imaging but know are there in 90% of patients. And we get more chemotherapy into the patient because about 1/4 of them will not be fit enough for chemotherapy after a pancreas surgery. The risk is the portion of patients who will progress and miss their chance at surgery. And that's psychologically very tough, but academically it's easy to sit back and say, well, that was bad biology and they were never going to do well with surgery. But it's something that if patients are going into that process, they should be aware that they may be foregoing surgery. The regimens with the most evidence in this setting are FOLFIRINOX and gemcitabine Abraxane, but really if we can give FOLFIRINOX, we do. And I'll talk about that more in a moment. Adjuvant chemotherapy, so treatment after surgery, really for every pancreas cancer resected, even in the T1N0 disease, which is very, very rare. We aim to give 6 months of treatment in total. And the regimens that we use, the oldest one that's done the most mileage for us is 6 months of gemcitabine, and that was first published in 2007. This is where where the curve here comes from that I've had on the screen without explaining for a little while now. This is the disease-free survival and overall survival from the gemcitabine and the darker curve on top there, and observation arms in the original adjuvant pancreas trial. And you see in these Kaplan-Meier curves that as you get out towards 5 years, the numbers of people still alive and recurrence-free goes down and down, and in the observation group gets to about 10% or less in both groups. So gemcitabine was the first major advance in this setting. And by giving 6 months of gemcitabine, we roughly doubled the overall survival of patients who had pancreas surgery. The next advance in this area came 10 years later, in 2017 with gemcitabine, capecitabine in what's called the SPAC4 trial. So this was the addition of a tablet to gemcitabine, still given for 6 months, and really quite toxic, but added about an extra 5% or so to overall survival. And then shortly after, we got the Prodigy 24 trial of FOLFIRINOX, which we've been using in the metastatic setting, now in the adjuvant setting. which brought the overall survival up to just above 30%. And with improved surgical techniques now, it's probably closer to 35 to 40% for all comers. So FOLFIRINOX, for most patients who are fit enough to undergo pancreas surgery, this is the regimen of choice post-operatively or neoadjuvantly for part of it. So we'll often give 3 months before surgery and 3 months after surgery. This is the reason for the going platinum in the title. So a platinum-based chemotherapy is what seems to be most effective in pancreas cancer. It may relate to how many of them have an underlying BRCA mutation, which we know relates to platinum sensitivity. And we also know that many more patients have underlying mutations than what we can detect on our current panels, because there's just not a lot that we know about genes and mutations compared to how much there actually is. FOLFIRINOX is toxic. We aim to give 6 months of treatment in total. The common toxicities that are predictable and everyone will get them are neuropathy. So about 2/3 of patients will get any grade neuropathy, meaning that they get a bit of numbness in their fingers and toes. And up to 10% will end with some deficit in function related to that neuropathy. We're getting better now at dialing down the dose before those permanent deficits appear, but it's still one that we've got to be very careful about. FOLFIRINOX is very myelosuppressive, and it's got a high enough rate of febrile neutropenia that we routinely give GCSF support for each cycle now. Patients are tired while they're on treatment. About 10% feel so tired that they just don't get out of bed a lot during treatment, which adds to things like increased clot risk. And a lot of patients get diarrhea, and this can be quite extreme and need them to come into hospital. Logistically, how it's done, they get a port put in just below the skin on the chest wall. They come in on day 1 of a 2-week cycle. They're in the chair for about 5 hours. Then they go home with a line attached to the port, which drips in the fluorouracil component of chemotherapy over the next 2 days. They come back on day 3 and get disconnected, which is very quick, takes about 20 minutes. And then they go home and try to forget about us for the remaining portion of that 2 weeks. They'll feel very tired during that first week and start to feel better during the second week, which is when we like to see them, when they're feeling a bit better. But obviously that's when we need to see them to see if they're safe to go ahead with the next cycle. So they'll get a blood test just before cycle 2 is due to start. We'll see if they're safe to go ahead on a myelosuppression side of things, and also to assess toxicities and see how we did and whether we need to adjust doses. Just before each cycle is a good time for them to have any procedures. So if there's essential dental procedures or vaccinations like flu vaccine things that they need to have, that's the time that they'll be most immunocompetent. And so the only risk with vaccines while you're on chemotherapy is obviously we wouldn't give live vaccines, but with attenuated vaccines, the risk is that they won't mount an effective response, so it'll be an ineffective vaccine. It's still a good idea for patients to have all of their COVID and flu vaccines whilst on treatment, and the way to maximise the effect of those is to give them just before a chemotherapy cycle, so that they mount a reasonable response. Adjuvant FOLFIRINOX, so this is what bumped up the 5-year overall survival to hopefully where we're at now, which is around 40% for all comers. Yeah. So stepping back from all of the chemotherapy that we give and delving into the world of anatomy, which we largely ignored in medical school, for me, probably not for you guys, presentation of pancreas cancer relates to its location as a retroperitoneal organ, and whether the lesion's in the head or the tail. So the majority of cases are head of pancreas lesions, about 2/3, and they're the ones that typically present with painless jaundice. So the other feature that patients commonly notice is weight loss. Steatorrhea, slightly less so. They might talk about having unusual fluffy stool that's very malodorous and floats. But jaundice and weight loss are the common features of head of pancreas lesions. Body and tail of pancreas lesions are less common, only about 25% of cases. They're the ones that present really late, as in they're much more likely to have nodal involvement or peritoneal spread because they don't obstruct the biliary system, so they don't present until they're large enough to cause pain. So a common feature that people talk about with tail of pancreas lesion is just weight loss of unknown cause. Somewhat scarily for you guys, I imagine, is that up to a quarter of cases of new diagnoses of pancreas cancer have had new onset diabetes in the last 2 years. But this is also an age group where diabetes is a really common diagnosis, and you certainly can't screen every patient for pancreas cancer who presents with diabetes. But it is worth thinking that if they've got other unusual sounding things in their history, particularly weight loss, back pain, unexplained blood clots, which often go with upper gastrointestinal cancers, particularly pancreas, it's very thrombogenic. That might be a person that you extend to do some baseline imaging on. Yeah. So the head of pancreas lesions and uncinate lesions generally undergo, if they're fit, a Whipple procedure. And this is a pancreatoduodenectomy where they cut out a lot of stuff. So the pancreas, the head of the pancreas, duodenum, plus or minus a bit of the stomach. So part of this is meant to be that it preserving the pylorus helps with gastric dumping. But depending on the anatomy of the tumour, they may need to take the distal stomach. The proximal jejunum, the gallbladder, and the common biliary and hepatic ducts. And then they join it all back together so that it works properly. What happens after a Whipple procedure relates to what they've cut out. So they've cutting out a large part of the pancreas, both the exocrine and the endocrine pancreas, which are all melded in together there in a roughly even distribution, although we'll talk about some differences in density in a moment. The exocrine pancreas is the acina and ductal tissue. It's the vast majority of the mass, and that's the part of the pancreas that produces nearly 1.5 liters a day ordinarily of pancreatic enzymes, water, bicarbonate in particular to neutralize all of the stomach acidity. So after people have had a Whipple's procedure, routinely they'll have loose bowel motions, some for many weeks to months. A lot of them improve without pancreatic enzyme replacements, though the stats on this is very difficult to get any consistency on. So probably about 40% will improve without any pancreas enzyme replacement over a month, and then another 20% or so over the next few months. But if there's persistent diarrhea, difficulty gaining weight, then we often just trial some Creon, which is a pancreas enzyme replacement, and they just take it pre-meals. They can go up to 100,000 units pre-meals. I usually start with 50,000 or 75,000 for a larger person pre-meals, just sort of start it with their first bite of a meal, and then 25,000 pre-snacks, and just give that a couple of weeks and see if it improves their symptoms at all. The endocrine pancreas is the pancreatic islets that we all learn about, the majority of which are the beta islets, which are the insulin producing part of the pancreas. The other islets are the somatostatin and glucagon producing cells that also matter, but you need them in a smaller amount to be sufficient. So they don't tend to be problematic after a Whipple's procedure. But in a head of pancreas resection, about 20% of patients will have post-operative diabetes, mostly not insulin dependent. Only about 6% of them will require insulin, but it's something we should routinely check after a Whipple's procedure. And it is logically that the more pancreas is cut out, the higher risk you are of developing post-operative diabetes. Distal pancreatectomy, so the smaller portion of cases, is a procedure that usually requires a splenectomy just due to the anatomy, dissecting off the splenic vein and getting complete margins at the distal end of the pancreas. They're very difficult, usually, I'm told, without doing a splenectomy. And also a lot of the regional nodes are shared, so they take those out too. So anyone plan for a distal pancreatectomy will have immunizations preoperatively in hospital. Sometimes they don't even know about it, I guess, with the all of the excitement or anxiety of an upcoming procedure, but it's fairly routine that they'll be given vaccinations for strep, meningitis and Haemophilus preoperatively, unless it's an emergency splenectomy, which most pancreas procedures are not. Then the rate of post-operative diabetes is slightly higher in distal pancreatectomies because the density of beta islets is slightly higher in the tail. So though they're taking less of the pancreas, there's slightly increased risk of diabetes. And notably, patients who've presented with chronic pancreatitis and they've had a lot of atrophy of their pancreas and islet death before surgery are at really high risk of post-op diabetes. So specifically looking at post-operative care for splenectomy patients, because this is something that comes up a little bit in the clinic. So the pre-op round, just to remind you, so it's the encapsulated bacteria that we're particularly worried about. They're the ones that, so the encapsulated bacteria have a polysaccharide coating that helps them avoid phagocytosis, so the innate system of engulfing bacteria and destroying bacteria. So they're more reliant on antibody dependent cell cytotoxicity, which the spleen as a primary lymphoid organ is very involved in. So the preoperative round of vaccinations will be given in hospital and includes those three listed there, four. Pneumococcal, if you forget everything else, pneumococcal is the main one. So these patients need their pneumovax vaccinations. This sort of accounts for about 70% of fatal sepsis in patients without a spleen. Generally, though, patients without a spleen are at 2 to 3 times greater risk of getting both an infection and also dying from their infection compared with the general population. So as well as their vaccinations, the first one pre-op, as I said, the second round of vaccinations should be given, we usually give it after completion of adjuvant chemotherapy if they're fit enough to have that. So at least 2 months after round 1, and 6 months is fine. And then boosters, they'll get 5 years later. But also they'll be on prophylactic antibiotics. So we usually use 250 milligram daily amoxil. The guidelines for splenectomy patients that have lost their spleen through trauma and are young and fit is to continue it for 2 years. But in most of these patients, they've got other comorbidities and other risk factors. So we just keep it going, ongoing. And then other things to consider are things like travel. They're at really high risk of death if they get types of malaria like falciparum. So malaria prophylaxis is important. Animal bites can be really bad in this population. So hospital referral for IV antibiotics is usually a good idea. And they may choose to have an alert bracelet, particularly if they're traveling. So to summarize, early PDAC, pancreas ductal adenocarcinoma, the definition of resectability is a moving target. This is something where high volume surgeons and centres is really important. So, you know, there's a few surgeons around Sydney who do a lot of pancreas surgery. We work a lot with some surgeons here who, I won't go into spruiking, but contact me. And yeah, so outcomes are generally better for high volume surgeons and centres. Chemotherapy is really important. It's really toxic, and a lot of it is a psychological challenge to get patients through because it's such a marathon, staring down 6 months of treatment, but it triples the rate of survival for resectable disease. And then surgical resection is fairly, it's not as morbid as you might think. So patients sort of are out of hospital within a couple of weeks. The procedure itself takes about 4 hours, and they're generally recovered sort of 6 to 8 weeks later, unless there's post-operative complications, which there's surprisingly few of. Diabetes and steatorrhea are particular things that we need to look out for post-operatively. We get dietitians involved fairly regularly to help with weight gain, and then dealing with all of the care requirements of splenectomy patients is important too. And that's it. And this is a slide that I added as Josh was talking, and I saw his slide that had his email and things, and I thought that sounded like a nice thing to do and made me seem inapproachable that I didn't have it. So this is my email, and Hurwitz Sim is the other medical oncologist who treats pancreas and upper GI cancers at St. Vincent's with me. And that's the GP can share details again too.
Thank you so much, Dr. Barnet. It was a really fantastic presentation, really comprehensive. There aren't any questions in the chat at the moment, so if anyone has any questions, if they could post them and we can go through them. We still have a bit of time for some Q&A. Can you see the question, Dr. Barnet?
I can. I love it. Why is tail of pancreas more common in women? Yeah, that's a good, I know that it is. Why is that the case? I don't know. It may, yeah, I would be, it may sort of have to do with anatomy and central adiposity and things like that, and how easily women feel retroperitoneal pain compared with men. But I don't have a good answer for that. That's something I should look into. Microbiome is a very big can of worms, as I'm sure you're aware. So we did some studies on microbiome in a recent project I'm working on, and we realized that microbiome is just so in its infancy in the moment. Everything that we think we know about it is very early on. So a lot of the articles, particularly the 3 that were published in Science back a few years ago, they really cherry pick a little bit. And I hope that, I'm presuming that none of the authors are on this call, but I think we're trying to make sense of it because we know it's important, and it's clearly important. There's trillions of bacteria in your gut that act as a priming agent for your entire immune system. So we know in immunotherapy, wiping out those bacteria with, for example, antibiotics is a poor is a bad thing to do and affects outcomes, but you can replace it with fecal microbial transplant and reinstate an effect for immunotherapy. Pancreas cancer is unique in that we give a lot of antibiotics because people present with biliary obstruction, sepsis, and they get antibiotic after antibiotic. So it's entirely likely, though not formally studied, that we are wiping out microbiomes. And microbiomes are really important in supporting chemotherapy responses as well as immunotherapy responses, because we also depend on immune cytotoxicity partnering with chemotherapy toxicity. So the specifics of fusobacteria, I think it's really too early to know which bacteria. I know that we think, Akkermansia is good, and some of the anaerobic species that we get in, what's the word? Fermented foods. So we think that fermented foods have good bacteria in them, and I really think it's all in its infancy. We try now to give as short as possible courses of antibiotics to patients and as narrow spectrum as we can. Patients often ask me about probiotics and prebiotics. I say I would avoid them unless you're seeing clinical benefit from it. I think firstly, we don't know what species we really want in the gut. Secondly, oral replacements that are in the supermarkets or the chemists really have no evidence as to how they actually affect the microbiome. So, at best, it's probably just making expensive poo, and at worst, you might be actually competitively antagonizing species that you do want with species that aren't that important. So microbiome is important. We're not there yet. Antibiotics are a problem, and that's probably all I can say about that. Hoped it helped. What about emerging novel therapies such as delivery of short-lived radioisotope lutetium housed in cryptate compound? So for early pancreas cancer, emerging novel therapies aren't there yet. So if a patient is fit enough for resection, we should still resect. And then the toxic 6 months of chemotherapy is not ideal, but it's still the best we've got. So emerging novel therapies don't play a role yet in resectable pancreas cancer. Lutetium is something that we use a lot in neuroendocrine tumors as something that's tagged to another compound like somatostatin that's then transported to cancer cells. So theoretically, if a patient wasn't an operative candidate, if we could, I'm not sure what cryptate compound is, but if that's something that tracks to pancreas, then that could be used. There was a trial of hyaluronidase to try to break down that stroma to help penetrate chemotherapy drugs in there, and that wasn't successful. But yeah, certainly radiotherapeutics is a big area evolving. Nothing in particular that I've seen that I'm excited about in pancreas yet. And we'd be testing it in the metastatic setting before we brought it forward to early disease. Pancreatic adenoma, how common is it, and is resection the treatment? That's a really big question. So I think the most common thing that we watch in incidental findings in imaging and stuff is IPMNs, which radiologists and upper GI surgeons sort of get together and discuss what the radiological features of a benign pancreas lesion are, and mostly they're called IPMNs. I'm blanking as to what that stands for at the moment, which is probably the equivalent to a pancreatic adenoma. So a lot of those, if they meet very definitive criteria, can be observed, but they follow up yearly with a pancreas surgeon who reviews the scan again and makes sure again that they haven't changed, because there is potential for them to progress to cancer. And if there's any doubt, they would then go ahead and get a Whipple's, which in a fit patient is actually really well tolerated. We are trying to find better ways of diagnosing pancreas cancer within IPMNs, but at the moment it's just regular imaging, regular review. Which investigation would you suggest for early diagnosis of pancreatic malignancy? Which pathology test can be requested? Yeah, so I think a large part of the reason I did not go into GP is because I was scared of all of the possibilities that come in to see you. And, you know, patients we see that have been diagnosed and sent through, it's always very astute work. So the CT of choice is, I mean, you'll see it with an ultrasound, which will then be escalated to a CT. That's really the test of choice. And with, particularly if you request a pancreas protocol CT, which just has a different contrast phase included as well as portal and venous, they really see quite well the anatomy and the nodal involvement within that. PET is something that you wouldn't order in the community. It's not indicated for pancreas cancer. We do use it to try to avoid operating on patients that shouldn't be operated on, but it's not PBS reimbursed for that reason. MRCP is more used when we want to sort of understand the ductal anatomy really closely as well. Yeah, so particularly in your new onset diabetes, unexplained weight loss, and I've got this weird clot in my arm, I'd be ordering a pancreas phase CT. And what is IPMN? Someone's highlighting the fact that I've forgotten what that stands for. But it's like, yeah, so intraductal papillary mucinous neoplasm. It's a benign precursor of malignancy. So like DCIS in breast. So anytime I see what is described as an IPMN, I refer them to an upper GI surgeon for follow-up. They won't necessarily operate, but they'll review it in an MDT setting and they'll follow it. And in a young patient, that might be followed for years, and any suggestion of change, they'll resect it, or any concerning features at baseline, they'll resect it. So I wouldn't do it by myself. I'd send to a surgeon to follow up.
I think that's all the questions, Dr. Barnet. So thank you again for coming to speak tonight, and thank you everyone for attending. Just a reminder to complete the survey. Lauren has posted a link in the chat, and yeah, we really appreciate your feedback. So please complete that at the end of the session, and enjoy the rest of your evening, everyone. Take care. Have a good night.